Well, hello, everybody. Welcome to Bucks County Orthopedic Specialist live Facebook feed for questions and answers about total knee replacement. Good? Oh, okay. So anyway, glad to have everyone with us today. Thanks for watching, coming out to watch the broadcast. And I hope I can answer some good questions about knee replacement. And I hope everyone is staying safe, and wanted to thank everyone who's worked so hard over at the hospital to take care of patients, and those members of Bucks County Orthopedic Specialists that have volunteered their time to help take care of those patients, and express my appreciation for that. So anyway, while the questions start to come in, I just want to say that knee replacement surgery has really been changing so much for the better over the past several years. And the main thing that has changed is a much greater focus on rapid recovery protocols. In 10 years ago, approximately, when I started doing in practice in joint replacement surgery, I think our average length of stay after a hip or knee replacement was 3.2 days. And with each passing year, the time that seemed to be necessary for patients to stay in the hospital went down and down and down, to the point that about 3 years ago, our average patient was only needing an overnight stay. And then, of course, the next question was, do people even need an overnight stay at all? So approximately 2 years ago, we started a program of going home the very same day as your replacement surgery. And basically, it's been a tremendous success. And it's one of the things that I'm most proud of in terms of how far we've come. And actually, Bucks County Orthopedic Specialists has been real leaders in the whole Philadelphia region on this. And I can touch on that a little bit more as to what I mean by that. But for example, earlier today, did 2 surgeries, and both patients already home in the safety and comfort of their house, being seen by a visiting nurse with very successful outcome. So anyway, I guess I'll start off with the questions. The first question is from Mary M. I've been getting shots for years in my right knee. Some days the pain is unbearable and disabling. I'm afraid of surgery, but I know I can't continue like this. I hope you can help me. Well, Mary, that's a really good question. I don't believe we've ever met face-to-face in the office, but if we were to, I would tell you to not be afraid of the surgery. One of the things that I think people are the most afraid of is that there's going to be a really excessive level of pain. And that problem has really been very substantially improved upon over the years. And the fact that a significant number of the surgeries we do nowadays are go home the very same day surgery should speak to that point. So basically, let's say 5 years ago, 10 years ago, the main focus was pretty much just giving patients what are called opiate pain medicines, the type of pain medicines that are habit forming that you've heard so much negative information about in the news. And what we discovered over time is that trying to fight pain using other types of medications has a very synergistic effect with traditional pain medications. So what I mean by that is that we try to fight the inflammation aspects of pain. We use advanced anesthesia techniques, and we use something called pre-surgery pre-medication. And what I mean by that is that I like to tell my patients, let's say, for example, you went to a rock concert or were using a chainsaw and it was super loud, and then you were driving home in your car later, your ears might be ringing. And the reason your ears ring after rock concert is because music is so loud, the nerves get sensitized, and they go into like a hyperactive mode. So basically what we do now is, even before the surgery starts, we give people pre-surgery medication, which helps to block the brain even knowing the pain is there from in the first place. Along those same lines, we also use a lot more regional anesthetic. And what that means is, instead of general anesthesia, where you're on a breathing machine, with a regional anesthesia, your legs are numbed you're sedated during the surgery. You don't feel anything, you don't hear anything, but your body is not aware of the fact that the surgery is being done. And that results in lower post-surgery pain. It's like basically if you went to a rock concert and you wore earplugs and then you drove home in your car, you might hear the music, but your ears aren't ringing because the pain was never to that same level of intensity. And then generally speaking, for hip and knee replacements nowadays, at the conclusion of the surgery, we inject anesthetic medication around the knee or the hip. And also for knees, do a nerve block at the conclusion of the surgery that helps to numb the knee itself, but not numb the muscles that make the knee bend and straighten. And what that does is it helps to carry through for as much as a whole day of reduced pain after the procedure's done. So, so basically, Mary, what I would say is if what's holding you back is the fear of pain with the surgery, you really shouldn't feel that way because things have come so far as compared with what you have probably heard about from years ago. It's just been a tremendous improvement. Okay, so let's go on with another question. Karen H asks, how long will Ortho Bisque last and when should I get a replacement? I guess we'll say in conjunction with the question of Ortho Bisque. So Ortho Bisque is a type of lubricating shot injection for the knee. And basically our knee makes natural lubricating fluid, but as every person grows older, the lubricating fluid in the knee is not as cushioning. And so synthetic lubricating fluid can be injected into the knee and help provide more cushioning. And along with cortisone shots, it's one of the main type of injection procedures we can do for helping to palliate or ease the pain prior to somebody selecting surgery. The thing about the injections, the Ortho Bisque injections, my experience with them is some patients respond very well to them, and other patients, they don't seem to do as well. And it's really difficult to predict which patient might have which outcome. So with cortisone, it seems like in most cases, a cortisone shot gives most patients relief. The question is, how long is the relief? With the Ortho Bisque, it seems more variable. So some people have tried medication, maintaining healthy weight, anti-inflammatory, cortisone shot. Then their arthritis keeps getting worse and worse. They think maybe I'll do the lubricating shot. If the lubricating shot is done and the knee is pretty much to the point where it's bone on bone, oftentimes those people don't get the same degree of relief. On the other side of the coin, if a patient feels like the Ortho Bisque or the other lubricant shots are working for them, and they feel in light of the fact that the lubricating shot is working, maybe they postpone surgery, there's no real harm for that as long as there's not damage to the bone from the wearing away of the two bones rubbing against one another. If it gets to be bone on bone and then the one bone starts to wear into the other bone, it can make the surgery a little bit more challenging and maybe not quite as optimal of a result, in which case I just suggest that we go on a patient-by-patient basis. But basically, to answer the question directly, it's very difficult to predict how long the results from Ortho Bisque might last. Some people have 6 months of relief. Some people don't find they get much relief even right out of the gate. It's very dependent on the person by person. And generally speaking, it is coinciding with how severe the arthritis is at the point when the injections are done. So those patients with bone on bone, they may not have great result with it, and they may just be better off doing the replacement. Okay, Tina asks, how are you handling COVID-19? Can I see you in the office? Well, that's a really good question. Basically, this has really turned everything upside down for orthopedics because we really do provide an essential service to those patients who injure themselves and have fractures. We see ankle fractures, hip fractures, wrist fractures, and they all need to be dealt with, or else the patient could have a lifetime of disability. So our office has been open during the COVID pandemic with a limited number of hours spacing the patients out so that there's not an overlap of patients in the office at the same time, using masks for the patients and the doctors and our physician assistants and our staff. With the fact that it seems like the pandemic has hit the crescendo, and with the fact that the Board of Health and the Department of Health in Bucks County indicates that there are way fewer cases of community spread of the virus, meaning spread outside of nursing facilities, et cetera. We are planning on reopening the office to more general orthopedic needs. And I'm sure that I've talked to many patients that we've been doing what are called telehealth visits on, which are video visits in addition to our in-person office visits for urgent matters. And those patients who are debilitated by osteoarthritis pain and in severe discomfort, I've done video visits with people in tears. So even though arthritis isn't an emergency like a fracture is, there are a lot of people who are very enthusiastic about trying to get back into the office and potentially get on the schedule to have their replacement done. In fact, I just ran into one of my patients in the hallway who's on the surgery schedule for Monday, and she moved her surgery up because it had become so debilitating while she's been waiting for the situation to get better. So that's a good question, Elaine. We'll be open to see regular orthopedic complaints. Some of us are starting this week, and the balance of the providers of Bucks County orthopedic specialists are starting next week for people's general orthopedic needs, maintaining the same precautions with spaced out appointments, masks, and we're actually even offering evening appointments with a wide array of our providers to make sure the patients are well spaced out during the day. So, and everyone who's looking at potentially a need for an office visit should have a lot of confidence about the precautions we're taking and the safety. Okay, Elaine asks, when is a replacement for bilateral knees appropriate? So that's a really good question. Bilateral knee means that both knee replacements are done at the same surgical setting. So you start on one side and you finish that one, and you move directly to the other side and you finish that one. And historically speaking, bilateral knee replacement has maybe been approximately 1 in 5 to 1 in 10 knee replacements done that way. And the basis for that has been patients who have significant enough arthritis on both sides that they would have done, they really need the replacement on both. I don't, generally speaking, advocate for people to do the other side if it's not significantly symptomatic. Like, it's not the kind of thing where if you are changing car tires, you change all 4 of them, or even though only 2 are worn down. That's not something we advocate for. So the interesting thing is that with the advent of truly go home the same day replacements, I see fewer patients opting for bilateral knee replacement. And the reason being that if a single knee replacement you can have as a procedure that takes 45 minutes and literally, I'm not exaggerating, literally be home in the comfort of your house 3 or 4 hours after the surgery, where it's a clean environment, it's a safe environment, you're not exposed to dangerous bacteria or germs to the level that you would be in a facility. That really appeals to the vast majority of people that I see that are trying to decide between what are called staged unilateral or staged single knees spaced out 2 or 3 months apart, or a simultaneous double. So I see more and more people opting to do a go home the same day single, followed by another go home the same day single 2 or 3 months later, and having a really fast recovery with that, because the recovery process from a go home the same day hip or knee replacement is really phenomenal. I mean, most of the people use a walker for about a week, a cane for about a week. I let many of my people drive in about 2 weeks after that surgery, and daily activities like doing grocery shopping or returning to work is typically about a month. With a double knee replacement, all of those things are pushed back quite a bit. And double knee replacement is always done as a stay in the hospital surgery. And in fact, a lot of people who have a double knee replacement historically have ended up going to nursing facilities, which I'm pretty sure that not a lot of people are going to want to opt to go that route, especially in the current environment when a single knee done in an outpatient basis potentially in a freestanding joint replacement specialty center is such an appealing option for people. Okay, so we have more questions. I understand there are different approaches to total hip. Which one do you prefer? Is that okay? It's about hip? Okay, so we're talking about knees, but that's okay. It's a hip question. So this is by Jed. So this question is referring to the surgical approach, or where the incision is positioned for total hip replacement. Historically speaking, about 3/4 or more of replacement surgeries are done with what's called posterior incision. And the incision for that is on the side of the hip, about at the back third of the hip area. And the advantage to that approach, and why it's historically been the most popular approach for hip replacement and still is that the parts are placed into the hip area with excellent alignment to the body's natural anatomy. When you do a hip replacement, you have to put a pin down the femur bone that's called the stem. And when the incision is placed in that location, because the hip readily bends forward, the incision is directly in line with the passage of the stem down the bone in a straight and facile manner. Approximately 5 to 10 years ago, there had been some growing enthusiasm about a type of hip replacement called anterior. And in an anterior hip replacement, the incision is on the front of the hip, in front of basically where the front pocket is on a pair of pants. And the purported advantage to that approach is that incision is done between two muscle groups so that the muscles are pushed out of the way, and the people that advocate for that approach argue no damage to the muscle is done. The initial enthusiasm about that approach has really significantly waned, however, because of many, many studies showing that the complication rate is much higher. So studies have shown that because the access to placing the pin down the femur bone is so much more difficult with the anterior incision, there's a much higher rate of inadvertently fracturing the bone during the surgery, or even worse, fracturing the bone and not recognizing it was fractured. And that can lead to really serious problems and the need for a redo surgery. And that risk is much higher with the anterior approach than the posterior approach. Another problem is that there's a nerve that cuts across the front of the thigh called the lateral femoral cutaneous nerve that does the sensation on the lateral or outside edge of the thigh. And that is damaged in as many as 1/3 of the surgeries, leading people to have a variable degree of numbness on their outer thigh, which a lot of people do not like at all. And furthermore, not only can you have numbness, but even worse is where you have what's called neuropathic pain, which is nerve pain. There's like a burning sensation, like a hot iron being put on the thigh that just never goes away, or takes years to go away. And the third thing is that the infection rate has been shown to be higher with a front incision or the anterior incision, because that crease where when you bend your leg forms a skin fold. Bacteria tend to accumulate in that area, and the infection rate has been proven to be higher. So I don't prefer to use that incision, nor do the rest of my partners, but some people have sort of marketed it over the years. However, I think that enthusiasm has really fallen off as more and more studies show a higher failure rate. And in fact, the award paper at the National Meeting of Joint Replacement Surgeons, which essentially almost all the joint replacement surgeons that specialize in this procedure full-time attend, the award paper out of hundreds of scholarly papers that are submitted for consideration was a study showing anterior approach has a higher failure rate than the posterior approach. Okay, so Barbara asks, what are the precautions after knee surgery? Well, actually, in contrast to hip replacement, Barbara, after knee replacement, there really aren't a lot of significant precautions. Once the knee is implanted and the cement or glue that holds the knee to the bone, like a grout, has set up, which occurs over the course of about 5 or 10 minutes during the surgery, and then the knee is closed up, you can really use it with full weight and essentially no restrictions. So, and that's exemplified by the fact that people are having surgery where they're walking an hour after surgery, like my patient earlier today, start surgery at 7:30, finish surgery at 8:15, walking on the knee at roughly 8:45 in the morning, and home in the comfort of her house by roughly 9:45 or 10 o'clock in the morning. Full weight, walking on the knee. Yes, using a walker for balance for the first week or so, but no restrictions on bending or the amount of weight. In fact, the more you bend it, the better. I do restrict people from driving for the first few weeks, depending on the patient's particular circumstances. And it's not quite a restriction, but one factor to keep in mind is that all patients who have a hip or knee replacement do have a risk of blood clot formation. So we put most patients on aspirin, some on other medications for blood clot prevention. And I wouldn't say that's a restriction, but it is an important fact to know about any replacement surgery. And that goes for about 1 month, and then those are discontinued. Okay, Mary Kay asks, what is the average recovery time for knee replacement? Well, for those patients opting for a go home the same day replacement, the surgery takes about 45 minutes. You're walking on the knee about an hour after surgery. You do about an hour or two of physical therapy at the replacement center, and then you're home in your house that very same morning. Our current protocol is that we have a visiting nurse and a visiting physical therapist meet patients at their house the day of the surgery, then again the next day. And from that point on, the patients go to physical therapy. And I would say the average patient uses a walker for about a week, cane for about a week, and then is walking unassisted thereafter. But everyone's different. It depends on how much pre-surgery capability the person had. Someone in the late 80s is not going to recover at the same rate as somebody in the late 50s or 60s, but it's a really fast recovery. Okay, Jim D asks, when is partial knee replacement appropriate and when is total replacement necessary? That's a really good question. So a partial knee, 70% of arthritis is located or starts on the inner half of the knee, what surgeons call the medial compartment. And because of that fact, it is possible to perform an isolated knee replacement called a partial knee replacement or a unicondylar knee replacement that only replaces the inner half of the knee. And the ideal candidate for that should be a patient whose arthritis is truly isolated to the inner half of the knee. The patient who has even the first signs of arthritis under the kneecap area or the lateral or outer compartment of the knee really shouldn't have a partial done, because what's going to happen is that over time, the arthritis in the untreated portions of the knee will continue to grow worse. And then you're going to have half of your knee replaced, but the other half of the knee will have progressively painful, worsening arthritis that still needs to be addressed. And so it's really made on a case-by-case basis, with the location of the arthritis being the main determinant. There are some surgeons that sort of advertise a partial knee maybe as a faster recovery or less invasive surgery, but really even a full replacement as such a fast recovery nowadays that you'd be foolhardy to choose a partial replacement thinking you were doing yourself a favor with a faster recovery, when in reality, if you have arthritis forming in the other areas of your knee, you would be needing to come back to have the partial removed and a full knee placed at a later date. So I don't think that's quite as desirable. Okay, so I think that was most of the questions that came in. And I just want to thank everyone for joining. And I just want to say that for those patients, like the very first patient, Mary, who are scared about surgery, you really shouldn't be. It revolutionizes patients' lives. And having been performing replacement surgery here in Doylestown for 11 years now, you see patients all over the place at the grocery store and Home Depot and other places like that. And they're so happy they did it. So, especially nowadays where we can truly go home the same day replacement surgery at a freestanding replacement center that's away from the hospital environment, not having to recover. People are not having to recover in nursing homes or rehabilitations or anything like that. It's much safer, much lower risk of infection, really fast recovery. And it's the way I see the majority of patients wanting to go that are, in generally speaking, good medical health. So thanks everyone for joining. And we're open for in-person visits. And by all means, please give us a call if you'd like to come in for a consultation. Thank you.